There is a conversation that I believe every woman deserves to have before she reaches her 60s. And the frustrating reality is that most never do. It's a conversation about the brain, about what actually happens to cognition during and after the menopause transition, about what the risk of dementia really looks like for women, why it differs from men, and, most importantly, what you can actually do about it. I want to have that conversation with you today. All of it. The parts that are reassuring and the parts that require action. Let me start with something that I think will immediately make you feel better, because I know that when women in their late 50s and 60s begin noticing changes in their memory, forgetting a name they've known for decades, walking into a room and losing the thread of why they went there, struggling to find a word that should come easily, the fear that follows is enormous. The word dementia appears in the mind before anything else. And I understand why. Because we have been told almost nothing about what is normal during this transition and what isn't. And in the absence of information, fear fills the gap. So here is the truth, plainly stated. Every woman who lives long enough will go through menopause, but only approximately 20% of women will develop Alzheimer's disease. Those two facts need to sit together in your mind. Menopause is universal, dementia is not. The cognitive experiences that happen during and around the menopause transition, the fog, the forgetfulness, the occasional sharp sense that your brain is not operating the way it used to, these are real, they are biological, and for the majority of women, they are temporary. That does not mean we should ignore them, quite the opposite. It means we should understand them properly so we can respond intelligently rather than from fear. Let me explain what the science actually shows about the menopause-brain connection. When estrogen levels begin to decline during the perimenopause transition, this affects the brain in measurable ways. Estrogen is not simply a reproductive hormone, it is a neurological hormone. It is active in the hippocampus, the brain region most closely associated with memory formation and retrieval. It influences the prefrontal cortex, which governs executive function, planning, and focus. It supports the production and availability of neurotransmitters, including serotonin, dopamine, and acetylcholine, all of which are involved in cognition, mood, and memory. When estrogen drops, all of these systems are disrupted to varying degrees. This is why the cognitive changes during perimenopause and early postmenopause are so consistent across women. They are not imagined, and they are not a sign of something catastrophic. They are a measurable consequence of a significant hormonal shift. Now here is where it gets more nuanced, and where I think the conversation needs to go beyond simple reassurance. Menopause does not cause dementia, but it is a period of life during which risk begins to diverge between women and men. Before menopause, women and men develop Alzheimer's disease at roughly similar rates. After menopause, women's risk increases relative to men's and continues to rise with each passing decade. This divergence is one of the most important and least discussed facts in women's health, and it is why understanding the menopause-brain connection is not just about managing brain fog in your 50s. It is about protecting your brain for the decades that follow. What drives this increased risk? This is where the research becomes genuinely fascinating, and also where the practical implications become clear. The first thing to understand is that menopause appears to act as what researchers sometimes call a risk multiplier. If other risk factors are present, metabolic dysfunction, insulin resistance, poor cardiovascular health, chronic inflammation, the hormonal disruption of menopause seems to amplify their effect on the brain. Women entering the menopausal transition with metabolic dysfunction tend to show more significant cognitive changes during that transition than women with better metabolic health. This is not a coincidence. The brain is metabolically extraordinarily demanding. It consumes roughly 20% of the body's total energy, despite accounting for only about 2% of body weight. When energy metabolism is disrupted, which is precisely what metabolic dysfunction represents, the brain is among the most vulnerable organs. This means that one of the most powerful things you can do for your long-term brain health is to address your metabolic health now, in your 60s. Blood sugar regulation, insulin sensitivity, cardiovascular function. These are brain health issues, not just heart health issues. They are not separate domains. The second important driver, and this one genuinely surprises most women when they hear it, is vasomotor symptoms. Hot flashes and night sweats are not just uncomfortable inconveniences. Research has shown that the frequency and severity of vasomotor symptoms are among the strongest predictors of cognitive changes during and after the menopause transition. Women who experience frequent, severe hot flashes tend to show more cognitive disruption than women with milder vasomotor symptoms, independent of the hormonal changes themselves. Why? The honest answer is that the research is still untangling this, but the leading explanations involve two mechanisms. The first is direct neurological disruption. The same hypothalamic changes that produce hot flashes also affect brain regions involved in memory and attention. The second, and I think this one is underappreciated, is sleep. Vasomotor symptoms are a primary driver of sleep disruption in postmenopausal women. Night sweats in particular fragment sleep architecture in ways that prevent the brain from completing the restorative processes that happen during deep sleep. The consolidation of memory, the clearance of metabolic waste products from neural tissue, the repair of cellular damage. When this happens night after night, week after week, month after month, the cumulative effect on cognitive function is substantial. So when women ask me whether the cognitive effects of vasomotor symptoms are from the symptoms themselves or from the sleep disruption they cause, my answer is both, and they compound each other. This is one of the clearest arguments for taking vasomotor symptoms seriously and addressing them actively, not simply enduring them. The third driver I want to highlight is one that is almost never discussed in relation to cognitive health during menopause, and that is nutrient status. Iron deficiency in particular is remarkably common in perimenopausal and early postmenopausal women, and is a well-documented but frequently overlooked contributor to cognitive symptoms. Brain fog, difficulty concentrating, impaired memory, all of these can result from suboptimal iron status, and they can be misattributed to the menopause transition when the underlying cause is actually nutritional. This is why I consider this period of life a critical window for thorough nutritional assessment. If you haven't had a comprehensive blood panel recently, including iron, ferritin, vitamin B12, vitamin D, folate, thyroid function, and fasting glucose and insulin, I would encourage you to prioritize that. Not because any of these results will necessarily require dramatic intervention, but because knowing your baseline gives you information. And information is what allows you to act strategically rather than reactively. Other nutritional factors with clear implications for brain health in postmenopausal women include omega-3 fatty acids, DHA in particular, which is a structural component of brain cell membranes and has been shown to reduce neuroinflammation. Magnesium, which plays a role in synaptic plasticity and is deficient in the majority of women over 60. And B vitamins, particularly B12, B6, and folate, which are essential for homocysteine metabolism. Elevated homocysteine being an established risk factor for cognitive decline and dementia. Now I want to address hormone therapy, because it is impossible to have this conversation honestly without touching on it. And the picture is genuinely more nuanced than either the enthusiasts or the detractors typically present. The question of whether menopausal hormone therapy directly prevents dementia has been studied extensively, and the current evidence suggests that the relationship is not straightforward. On its own, hormone therapy does not appear to dramatically reduce dementia risk in the way that, for example, cardiovascular medication reduces heart attack risk. But here is what I think is the more important framing. Hormone therapy can significantly improve quality of life, reducing vasomotor symptoms, improving sleep, stabilizing mood, maintaining energy and sexual function. And all of those improvements have indirect but meaningful effects on the brain. If addressing your vasomotor symptoms allows you to sleep properly for the first time in years, that is a brain health intervention. If it restores your energy sufficiently to exercise consistently, that is a brain health intervention. If it stabilizes your mood enough to maintain social engagement, that is a brain health intervention. The brain benefits of hormone therapy, where they exist, are likely largely indirect, mediated through better sleep, reduced vasomotor disruption, improved mood, and greater capacity to engage in the lifestyle behaviors that directly protect the brain. This is not a dismissal of hormone therapy. It is an argument for understanding what it actually does, so your expectations are accurate and your decisions are informed. So what does a practical brain protection protocol look like for a woman in her 60s? Let me be specific, because I think specificity is what most women have been denied. Movement is the single most powerful brain protective intervention available to you without a prescription. And I want to be precise about what kind of movement matters most. Aerobic exercise. Brisk walking, cycling, swimming increases blood flow to the brain, promotes the production of BDNF, which is brain-derived neurotrophic factor, a protein that supports the survival and growth of neurons and has been called fertilizer for the brain. The research on aerobic exercise and dementia prevention is among the most consistent in all of medicine. Aim for at least 150 minutes per week of moderate intensity aerobic activity, broken into sessions that suit your schedule. Resistance training adds an additional layer of benefit, both directly through its effects on metabolism and inflammation, and indirectly through its role in maintaining physical capacity and independence. Sleep. I have already said this, but I want to say it again. Prioritizing sleep is a brain health decision. 7 to 8 hours of quality sleep per night is associated with significantly lower dementia risk in large-scale studies. If vasomotor symptoms are disrupting your sleep, address them. This is not about comfort, it is about long-term neurological health. Social connection is another factor that the research consistently identifies as protective against cognitive decline, and it is consistently underrated in public health messaging. Loneliness and social isolation increase dementia risk at a level comparable to major physical risk factors. The relationships you maintain and invest in during your 60s and 70s are not peripheral to your health, they are central to it. Prioritize them accordingly. Cognitive engagement is the fourth pillar. The principle here is straightforward. The brain retains what it uses. Functions you challenge regularly tend to be preserved longer than functions you allow to go unchallenged. This does not mean you need to do specific brain training exercises. The evidence on those is mixed at best. What the evidence does support is learning new skills, things that are genuinely challenging, that require concentration and sustained effort. A new language, a musical instrument, a craft that involves spatial reasoning. The complexity of what you are learning matters more than the category. If it feels difficult, that difficulty is the point. It is the stimulus for neural adaptation. Metabolic health management rounds out the protocol. Keep your blood sugar stable through the quality and composition of your diet. Prioritize protein. Postmenopausal women are consistently under-consuming protein, and protein adequacy is important for both muscle and cognitive health. Reduce ultra-processed foods, which drive inflammation. Support your gut microbiome with diversity of plant foods, as emerging research on the gut-brain axis suggests that gut health influences neuroinflammation and cognitive function in ways that we are only beginning to understand. And attend to your nutritional status specifically. Ensure your omega-3 intake is adequate, 1 to 2 grams of combined EPA and DHA daily through either diet or supplementation. Have your vitamin D levels checked and maintain them in an optimal range. Address iron status if it is suboptimal. Ensure B12 is adequate, a nutrient that becomes harder to absorb from food with age and one that is absolutely critical for neurological function. I want to close by saying something that I mean genuinely. The picture for postmenopausal women and brain health is not as dark as the headlines sometimes suggest. The majority of cognitive changes that women experience during the menopause transition are temporary and reversible. Long-term studies consistently show that well-being, wisdom, and overall cognitive satisfaction tend to improve in the years following the transition, once the acute disruption of hormonal change has settled. What the science asks of us is not passivity in the face of these changes, but informed engagement. The window of your 60s is genuinely important, not because decline is inevitable, but because the choices you make during this decade lay the neurological groundwork for the decades that follow. You have more agency in this than you have probably been led to believe. As always, I want to be transparent about what I am and what I am not. I am a scientist and educator, Nothing I have shared today constitutes medical advice, and all decisions about your health, including hormone therapy, supplementation, and screening, should be made in partnership with a qualified healthcare provider who knows your full medical history. The information I share is intended to help you ask better questions and have more informed conversations. What you do with it is yours to decide. Thank you for being here. Look after your brain. It is, quite literally, everything.